The next half an hour, I'd like to cover an approach to a requisition from the emergency room for rule out ectopic pregnancy, also approach for benign versus malignant ovarian masses and how to recognize ovarian torsion and also how to recognize the abnormal endometrium. So we're going to start out with a couple of cases. So the first case is a 24-year-old female with pelvic pain. She has a positive pregnancy test, and I'd like you to make a couple observations. Just give you a few seconds. Here's an empty uterus, and the image of the upper abdomen demonstrates intra-abdominal fluid. This is a companion slide, same case, and this is a view from the cul-de-sac. And the observations here is blood in the cul-de-sac. So at this time, as you can see here, complex fluid, also not only simple fluid in the cul-de-sac. The diagnosis here, you should entertain is ruptured ectopic pregnancy. Next case is a young woman, 24, with pelvic fullness. The question I have here, is this a benign or a malignant process? This is benign. Mature teratoma is somewhat unusual appearance of it, but you could see these fat globules and then keratin fibers within this lesion. Next case is 42-year-old female with irregular periods. Observations here I'd like you to make is focal thickening of the endometrium and a single feeding vascular pedicle to this area of focal thickening. Same case continued. This is a saline-infused sonogram of the same patient. And you could see a polypoid lesion with smooth margins. So here the diagnosis is polyp, and again you can see the single feeding vessels to the lesion. Case 4 is a postmenopausal patient with bleeding. This is not a saline-infused sonogram. So observations here I wanted you to make is a focal mass with irregular margins, and also that there's fluid in the canal, and this is not, as I said, saline-infused sonogram, but also that the fluid is echogenic. The same case continued here. This mass is highly vascular, and so my question is this a benign or a malignant process? You should right away think this is endometrial cancer until proven otherwise. Last case is a 24-year-old woman with anemia. This is a saline-infused sonogram. And you should notice that the lesion is actually arising from the myometrium. And the diagnosis here is an intracavitary fibroid. Okay, moving on now, we're going to spend some time on how to approach ectopic pregnancy. We know all of the classic triad of the ectopic pregnancy, which is irregular bleeding, abdominal or pelvic pain, and palpated tender adnexal mass. But this kind of presentation is only present in about 45% of patients. And as we know, not every ectopic pregnancy has read the books. So we have to particularly pay attention to high-risk patients who have abnormal fallopian tubes due to infection, surgery, or congenital abnormalities, or patients who have normal fallopian tubes or have an IUD or have gone through IVF. And also, it's very important to acquire about the history of prior ectopic pregnancy. So the high-risk groups are the source of asymptomatic patients who are referred to us to rule out an ectopic pregnancy. But essentially, any woman of childbearing age is at risk to harbor an ectopic pregnancy. So tests what we have available are blood and urine tests, which are very sensitive. There's no false positive diagnosis, but it can be false negative when the levels are too low to detect. Ultrasound is very helpful, and we're going through the review of the presence and absence of certain intrauterine findings, what we would be looking for. So the definition and location of ectopic pregnancy is really an implantation of a fertilized ovum outside of the endometrial lining of the uterus. It's most common within the fallopian tube, as you see, 95 to 97%, and it's very rare within the ovary, only 1%. It can occur in other places such as broad ligament and perineal surface, also very rare. But it's often not possible to predict the exact anatomic location on imaging. You can also have an ectopic pregnancy within the uterus, cornual interstitial ectopic pregnancy, which is also rare, less than 5%, but it does happen, within the cervix, and within the cervical C-section scar. Very rare, but we need to be aware of this, because all of those ectopic pregnancies have just as detrimental effects as the extrauterine ectopic pregnancies. Here's an example of a very unusual ectopic pregnancy within the C-section scar. It's a longitudinal endovaginal view of the uterus, and you see the scar anteriorly and a pregnancy within the C-section scar. Heterotopic pregnancies are concomitant intrauterine and extrauterine pregnancies. They're very rare, but they do occur, and they're related to damaged fallopian tubes and use of assisted reproductive techniques. So essentially, if the patient has a positive pregnancy test, the differential should include normal early intrauterine pregnancy, abnormal intrauterine pregnancy, ectopic pregnancy, or too early to detect an intrauterine pregnancy. Here are some reliable morphologic criteria to diagnose an intrauterine pregnancy, and going down the list, they have an increasing certainty, and these numbers, especially the heartbeat at 6.5 weeks, we oftentimes use as a cutoff value to determine if there is an early pregnancy failure. Or you could use numbers such as the mean sac diameter, 8 millimeters, you should see a yolk sac. Mean sac diameter is 16 millimeters, you should see an embryo, and ground rump length 5 millimeters should have a heart rate. So here are some of the imaging findings of an early intrauterine pregnancy. You could see the yolk sac. You could see the yolk sac and a very small 2 millimeter fetal pole. And the same tiny little fetal pole at this time also already has a heart rate, which is often the case. So if you see an intrauterine pregnancy, the ectopic risk is almost near zero. But if you don't see an intrauterine pregnancy, the ectopic risk goes up to 55%. So women with a positive beta ECG, how does sonography help us? If on sonography we have an intrauterine pregnancy, it could be normal or abnormal, we could see the ectopic, it could be as spontaneous abortion or too early to detect. So criteria to diagnose an ectopic pregnancy, the adnexal findings are free fluid. Oftentimes the fluid is complex. You could see an adnexal mass, echogenic ring, gestational sac. You could even see a yolk sac or a fetal pole. Here's the patient what I showed you earlier during the cases who has free fluid, complex free fluid, which represents blood in the cul-de-sac. Here's a patient who has an echogenic mass, and notice how it's separate from the ovary, which you see right next to it. Again, a patient with an ovary separate from an echogenic mass. Within the ovary, you can actually see the corpus luteum. Sometimes it's difficult to separate the corpus luteum from the ectopic pregnancy. So it's very important to actually look at the real-time images, and sometimes, if necessary, actually go in the room and obtain more images to see if you see ovarian tissue around the echogenic ring, then you're almost certain that this is a corpus luteum and it's within the ovary, because I want you to remember that it's very rare to actually have an ectopic pregnancy within the ovary. So here's an example where you see this echogenic mass-like thing ring within the ovary. And this, if you would look at the cine loops, you could clearly see the claw sign of the ovary and ovarian tissue all around this. And this is a corpus luteum. And here's some Doppler images of the same finding. And again, you can certainly tell that this is corpus luteum. On the contrary, on this case, where you see an ovary, and right next to it, you see an echogenic ring. And then at this time, you should definitely suspect that this is an ectopic pregnancy until proven otherwise. So here's an echogenic hypervascular ring outside of the uterus within the adnexa. You can even see a little bit of a yolk sac in there. This is an ectopic until proven otherwise. Here with flow. Echogenic ring with more obvious yolk sac outside of a uterus. Immediately you suspect this is an ectopic. Echogenic hypervascular ring and mass. And sometimes you can also detect actually heart rate within that echogenic mass, even though you don't actually see the ground rump or the fetal pole. So if you have no intrauterine pregnancy, risk of ectopic, as we said, was 55%. Now, if you see the presence of pelvic fluid, the risk increases up to 75%. Any mass, the risk is up to 75%. But of course, if you see an adnexal yolk sac and embryo, that this diagnosis is 100% that you have an ectopic pregnancy. But you have to remember that it's quite difficult to always see the ectopic pregnancy on imaging, and the sensitivity ranges all the way from 15 to 35%. So as we said, if the risk of ectopic was 55%, given if there is mass or fluid, it increases. But if there is no fluid or mass, the risk of ectopic pregnancy actually decreases down to 7 to 33%. You can also look at some other intrauterine findings, which are not so specific, because the endometrial can be normal. The endometrium can be thickened, heterogeneous. You can have decidual cyst and pseudogestational sac, but it's only present about 5% of ectopic, so it's not very reliable. This is sort of a summary. If a patient presented to the emergency room had a clinically suspected ectopic, so the risk was about 15%. Then you did the ultrasound, so you saw the intrauterine pregnancy. The risk was about nearly zero. Then if there is no intrauterine pregnancy, the risk is 55%. You saw the adnexal mass, embryo, or fluid, the risk increases all the way up to 100. But if you see no mass, no fluid, the risk, of course, decreases, but it's still twice the initial risk. So at that time, you would recommend as appropriate whether to follow up with imaging or beta ECG. So why is ectopic such a big deal? It's because the severe pelvic pain and hypotension is present only in minority in patients, and rapid deterioration can happen if the diagnosis is not quickly established. It's also important because rushing to treatment, which is unnecessary, will result in loss of a normal pregnancy. Moving on to ovarian masses and what to look for. First, the approximately 70% of excised ovarian neoplasms are greater than 6 centimeters. Smaller masses should have a compelling clinical reason for excision. What are the compelling reasons for that? Is if the patient is symptomatic, patient's age, discovered during surgery for other reasons, and obviously if the adnexal process has a highly suspicious sonographic appearance for malignancy. Almost certainly benign lesions in premenopausal women are anechoic unilocular thin wall cyst less than 10 centimeters. Also hemorrhage into a unilocular cyst, old blood in a unilocular cyst, thin wall cysts when the septations are less than 3 millimeters or they're less than 3 septations. Any mass with high amplitude regional echoes and acoustic shadowing, which is the characteristic appearance of dermoids. The list is much shorter for the postmenopausal patients. It's only unilocular thin-walled anechoic cyst less than 5 centimeters. So here are the examples of a totally benign appearing unilocular cyst. Here are the examples of complex cysts, which are also benign, such as hemorrhagic cysts. You see internal lace-like fibrinous bands, and they appear to be contracting rather than expanding. And having these kind of appearance, you're almost certain that this is a benign process and hemorrhagic cyst. Here you can see an old hemorrhagic cyst, the retractile appearance of this hemorrhagic clot, and there is no flow in this. Other benign complex cysts are endometriomas, mature teratomas as dermoid cysts, and as we already talked about, hemorrhagic cysts. So here's a typical appearance of endometrioma, internal low-level echoes, good through transmission, and the things what you're looking for is any possible mural nodules on any solid components in this, which would lead you to think that this is possibility of malignancy or something developing within a benign endometrioma. Other examples of nice internal low-level echoes, good through transmission, and sometimes in postmenopausal patients and older endometriomas, echoes within the lesion can be somewhat brighter because these are cholesterol deposits and they're not as low-level echoes as we are expected to normally see. Here are examples of other complex cysts are mature teratomas, the very typical appearance of the dot dash and the dermoid plug. And as I showed you, somewhat atypical, but still you can recognize these are fat globules within the immature teratoma and the keratin fibers. So what are the characteristics of high probability of being malignant? Irregular walls, mural septal nodules, thick septations, large multiseptated lesions, and solid lesion except fibromas. So here's a typical example of a clearly malignant lesion with thick walls, mural nodules, and this is malignant until proven otherwise. Here's another high probability of being malignant lesion. You can also see ascites. It's a postmenopausal uterus. You see fluid within the canal, and you see large ovaries. Another thing I want you to think about, if you see bilateral ovarian solid masses, oftentimes you should query if there is a history of other malignancy, because bilateral solid masses would be more indicative of metastatic disease rather than primary ovarian malignancy. So the management paradigm for adnexal masses, what I'd recommend would be, if they're clear benign on ultrasound, follow up as clinically indicated. If the lesions are indeterminate on ultrasound, MRI is often helpful to determine whether these lesions are benign or malignant. For instance, to help to confirm that these are blood products within the lesion or fat, as in dermoids, and also if they're to confirm that there are no enhancing components to this. Also, in a pregnant patient, MRI can be helpful to defer surgery to after postpartum, although we are limited with MRI because of the inability to give contrast. If the lesions are malignant on ultrasound, but clinically you have a low suspicion, then also you should investigate this further and see if you could possibly determine on MRI whether it could still be a benign lesion. And of course, if it is malignant on ultrasound and you have a high suspicion, most of the time patients go to surgery, but pre-staging CT or MRI is helpful. Moving on to ovarian torsion, it's 2.7% of gynecologic operative emergencies. Most common in reproductive age patients, 20% occurs during pregnancy. And for some reason, right-sided is more common, and it's explained that sigmoid colon protects the left side from torsing. And also occasionally there's a lead point, such as ovarian mass. However, may present at any time in the female life from childhood to postmenopausal period. So the clinical symptoms in ovarian torsion are very important. Patients usually have acute severe unilateral pain, anorexia, nausea, and vomiting. They have intermittent pain, which may precede acute symptoms. And also symptoms can be mimicked by other pelvic processes, especially appendicitis in young patients. So the imaging findings, the torsed ovary has to be enlarged, at least greater than 4 centimeters. It's usually heterogeneous. It's edematous. There is internal hemorrhage and necrosis. And the follicles, due to this process, what happens to the ovarian stroma, are pushed to the periphery. It's most of the time also a unilateral process. And then pelvic fluid can be or cannot be present. You can look for a twisted vascular pedicle, which is called a whirlpool or a target sign. If you see it, it's great, but it's reported to be there at 88% of time, but just from experience, I have to say that it's certainly not the first thing what we see during ovarian torsion. But again, if you see it, it's clear that that's what it is. Now, Doppler, it's very important, but it is limited, because if you do see flow within this abnormally enlarged ovary, it doesn't mean that it excludes the torsion, because the torsion can also be intermittent. And if you do have a leading mass, it's oftentimes greater than 4 centimeters, and dermoids are quite common leading masses. So here's an example of a torsed ovary, enlarged stroma with follicles pushed to the periphery. And here you can see on Doppler of the same examination, you can see there is no internal flow and no parenchymal flow in this ovary. Here again, very typical imaging findings, enlarged, and the follicles are pushed to the periphery. It's this almost string of pearls sign, and internal ovarian stroma is heterogeneous, echogenic. And this is a classic appearance of an ovarian torsion, and of course, it's most of the time unilateral. Here is the target sign when you could actually see the torsion within the broad ligament. So the highest predictive value for imaging is, as I said, enlarged ovary with abnormal Doppler and presence of fluid in a cul-de-sac in a patient with an acute pelvic pain. Why is it so important? Is because prompt diagnosis and surgical repair will prevent irreversible adnexal damage. Moving on to endometrium and briefly evaluating the endometrial normal and abnormal endometrium. Since we use certain numbers, the measurement technique is very important. Normal values for premenopausal patients, they range from menstrual 1 to 4 millimeters, proliferative 4 to 8 millimeters, and secretory 8 to 16 millimeters. Here are the different appearances. Now the measurement, I want you to notice, it's from the echogenic line to echogenic line. This first one, you see nice thin postmenstrual endometrium. Then proliferative, the trilaminar appearance of the endometrium. And then the secretory endometrium. And again, even though there are certain numbers given to describe those premenopausal appearances of the endometrium, even if you have higher than 17, almost like 22 millimeters, it could still be within normal range. You would just have to look into the clinical history or maybe evaluate the patient at a different time during her cycle. Now, postmenopausal, on the other hand, if the patient is non-bleeding, the endometrium should not be greater than 8 millimeters, but if the patient is bleeding, it should not be greater than 5 millimeters. If the endometrial stripe is less than 5 millimeters, the bleeding is likely due to atrophy. But if it's greater than 5 millimeters, it's likely due to carcinoma hyperplasia, and at that time, or also could be due to polyps, but at that time, tissue sampling is recommended. Now, the postmenopausal fluid in the canal is never normal, but most of the time it's due to cervical stenosis. But you should be really aware of imaging, or while you see the fluid within the endometrial canal, whether it's echogenic or not echogenic and how much fluid is there, because there should certainly be suspicion for endometrial or cervical cancer when you see fluid in the canal. Now, always we talk about endometrium, we have to mention tamoxifen because it has a very characteristic appearance on imaging. Tamoxifen has estrogenic effect. It causes hyperplasia and cystic changes, which are endometrial and subendometrial. And ultrasound is unable to distinguish between cystic endometrial hyperplasia or carcinoma. So we see these findings and we describe them, but really if the clinical suspicion is high, tissue sampling should be performed rather than following those patients with imaging. Here you can see a very typical appearance of thickened cystic endometrium. And in summary, we reviewed the approach to ectopic pregnancy, also how to separate corpus luteum from an ectopic pregnancy, how to recognize malignant lesions in the nexa, and the very classic appearance of ovarian torsion with edematous stroma, enlarged ovary, follicles pushed to the periphery, and recognizing the endometrial cancer when you see it.